Dr. Mikel Sánchez, Scientific Director and Doctor from the Arthroscopy Surgery Unit, Vitoria, Gasteiz, who is here to speak of regenerative medicine for you all, patients with osteoarthritis. Welcome, Doctor. Good morning, everyone. Thank you. Thank you, OAFI. And congratulations, Dr. Vergés, for your role defending patients with this wear in their joints. So congratulations. Keep up the good work. Everyone knows osteoarthritis is a more and more prevalent disease. Above 60 years, up to 13% of the population suffer from osteoarthritis. Currently, over 250 million patients with osteoarthritis worldwide that we know of, diagnosed. Of course, there must be many more. And this grows more and more because our patient is older and we exercise and we do sports not in the best way. In the end, it's a degeneration of the joints. It's chronic, there's no cure, and it worsens with time. It is associated to getting older, to age, and to overweight. One of the pathologies that most limits the quality of life of our patients in a knee osteoarthritis, no one will die of this like in a tumor, but it does have an impact, a negative impact on their quality of life and forever. We always have to consider the joint as an organ, as a full organ. The cartilage is the tissue that we see degenerate, as we see here, normal white cartilage, how it wears and disappears. And this is something that evolves with time in phases. It softens, it breaks, ulcerates, and ends up disappearing. But there are other tissues in the joint. This is what we see. But there are other things involved, like the synovial membrane or the subchondral bone under the cartilage, which is the most important structure. So why is this cartilage damaged? There are two reasons, basically. One is for mechanical reasons. With a healthy cartilage, we have an excessive load because of trauma, because the legs are crooked, or because of overweight, and it deteriorates. Or we could have poor quality cartilage because there is a rheumatoid or metabolic disease with normal load. A thin patient can also have osteoarthritis. In the end, for whatever reason, we break the balance between the cartilage we make and the cartilage we wear. The imbalance moves to catabolism, the joint destruction, and the progressive osteoarthritis appears. As we see in these images, this is an MRI of a healthy young knee. These black triangles are the menisci. This clear layer is the joint cartilage. When there's a meniscal lesion, the dampening structure disappears, and progressively the lack of meniscus could lead to the full destruction of the joint. This is a mechanical cause for a meniscal cause. And then the knee, all the cells in the knee have to get accustomed to these changes in the weight load to adapt. And it's the chondrocyte, the cartilage cell, that feels this overload and these alterations. But most likely, the problem lies in the subchondral bone, where the degenerative loop appears. The cartilage sends messages to the subchondral bone, and this synthesizes proteins going to the joint, destroying it. What happens in the subchondral bone? Many things happen. We won't go into detail, but in the end, the bone marrow is replaced by a new tissue, which is fibroneurovascular, with the growth of new vessels and nerve endings that are responsible for that pain. Cartilage has no nerve endings. It never hurts. What hurts is the synovial membrane or the subchondral bone. And so this is why we have edema in the MRI images. Those white spots, poor prognosis, because the evolution will be worse and pain will appear. And this is an idea that no one paid attention to, but which was published In 1972, 50 years ago, already proposed that the cartilage could be victim of other things in the joint. And the end of this pathology is a knee prosthesis, which is usually a nice surgery, but not always, and with a limited life. After years, the prosthesis deteriorates, it loosens, the material could wear because it's synthetic, and we have to exchange it, and that's not easy. We lose bone. There are more aggressive surgeries. So the idea is to try to avoid to get to that, postpone that joint prosthesis. This is the cartilage that, with lack of cartilage, we can make it regenerate tissue that is similar to cartilage and will last for 2 more years. As you see in this video, this is a former athlete who had the meniscus removed 10 years back, and he came to see us with this lesion, this loss of joint cartilage. So we removed the pathological cartilage that was dying, and we infiltrated growth factors and PRP in the bone. We stimulate stem cells that Sol Ruiz told us about. And 9 months later, we see that a white tissue has appeared again. It's hard, it's shiny, and it resembles cartilage. The patient remains asymptomatic, and this is what we want. We know that in surgery we can achieve this. We'll try to do this without operating. And what are the most frequent causes, besides rheumatic disease, for this degeneration of the joint? Overweight and lack of exercise. They usually go hand in hand. If someone is overweight, it's hard for them to exercise, and someone who doesn't exercise, it's very difficult for them to lose weight. But what is exercise? Is sports healthy? Are these competitions healthy? Is all this healthy? Elite sports, professional sports, where things like these happen, I don't know. This is a soccer player after that accident. It seems like they're more in the war rather than playing football. Had a very severe knee lesion, who had to undergo an operation, and this is an important risk factor for osteoarthritis. But there are other things. Professional sports move a lot of money. Professionals are not always the best, the ones taking care of professional athletes. I'm sure that these guys were from the other team who just drop him there. All this, is this sports, or this other guy who damaged his ankle and he had to go to the ENT instead of the trauma doctor. No, I'm just joking. Speaking of exercise, we're speaking of this exercise. Healthy sports done regularly without any competition or aiming for no medals. This exercise is good for everyone, for every part of the body, including the brain. We all must exercise. We are designed to exercise. To be sedentary is as bad as to do sports. And you see, today we had no elevator, so that we had to walk up the stairs. It's as bad to not do anything as to do too much. And then we have, given a chronic, poor prognosis situation with poor chances of curing without surgery, with biological treatment, can we delay the prosthesis, or can we even avoid it? Of the cells we heard from Sol Ruiz, outside of clinical trials, we could not use it in regular patients. As admitted therapy, we have cell signals. With the cells fixed, as you saw, in the membrane of a cell, producing a stimulus in the cell that reaches the nucleus, and the cell responds, in this case, multiplying. Other times it synthesizes a protein with an outer signal. A cell does something. If we sunbathe, the skin cells, melanocytes, synthesize melanin, and we get tan. If we don't sunbathe, those cells will not make us tan. That's why these are called cell signals with low molecular weight proteins that are found in different cells. And these proteins are always efficacious because they are if there are cells. This is a very interesting paper crossing the blood flow of very old with very young mice. And what happens to the old mouse with the cell signals from the young mouse is cells rejuvenate and the old mouse rejuvenates, getting its memory back with more hair growth, more active. And these growth factors are especially in platelets, but there are many in plasma with the exosomes and those vesicles. And in all cells, they can all synthesize growth factors under the right stimulus. Anyway, we all know how what plasma-rich platelets are. It's like a great bag of proteins with alpha granules that contain the growth factors, but it's just a small part of the platelet. When we concentrate platelets, we concentrate everything in the platelet, not just these alpha granules of the platelets. And it's well known in the lab, all the actions of these growth factors, and it's very easy to verify in the lab. In cell cultures, it's easy to see how if we use a control culture or another one with growth factors on the right, you see how the cells multiply more, they migrate more, they're more alive, they do more things. We can see and measure this in the lab, but there's a great controversy of the clinical results. We've seen this is in the blood, what we do, centrifuging a small amount of blood, we separate in fractions after centrifuging. In yellow, we have the plasma with platelets, then we have the white blood cells and the red blood cells that we will discard. And there's been a commercial war here. We have over 50 systems in the market with yellow and red products, orange products, and we all call them platelet-rich plasma. They're all different products, most likely. So where does this come from? The first time someone spoke of growth factors was Rita Levi-Montalcini in 1948. He got the Nobel Prize years later for that. Why was Spain known for these? This comes from the world of teeth, or someone developed a system to concentrate plasma rich in growth factors with small amounts of blood, not like in the United States with half a liter required, with calcium chloride. And in 2000, he also, Anitoine, convinced me to use it and took me out of the OR for some days to do investigation. We started with the locomotive apparatus. We bought a herd of sheep, who I really thank them for everything they taught us and everything they've let us do on them so that we learn. You see them limping like us, and we learned all the treatments and the protocols that we use currently. And we spent the weekends and our free time studying this for many years, and we developed the protocols for the treatment of osteoarthritis. This reached the world of sports, and thanks to this, the athletes heal sooner and they get back to work sooner. And this has led to a lot of controversy. What about the scientific evidence? This is the most boring part of my talk because there is very much scientific evidence on osteoarthritis. I will just speak of the latest, of the last year and a half. There's been a consensus on the ESCA, European Association for Knee Surgery and Arthroscopy, a consensus studying the efficacy of PRP in osteoarthritis in the knee. Initiated in September 2020, finished in April 2022. There were working groups, one steering group that proposed the problems that had to be overcome. Another group would revise the scientific literature. There were, after a year and a half of work, we reached a consensus which was presented in the ESCA Congress in Paris a few months ago. So within the steering group, there are three from this country: Ramon Cugat, Ferran Abad, and myself in the steering group in Europe. No other country. Italy had other three, yes. And what we did was decide what grade of scientific evidence our responses had and what grade of agreement in the group with over 100 people that had to agree on this. We divided it in three groups of questions: indications, ideal plasma, and how to do it. Every question was a pain. We had the question. We answered after reading many scientific papers, and we all reached a conclusion together. So the main conclusions we reached on osteoarthritis: there's scientific evidence to use PRP for the initial treatment of moderate osteoarthritis. Scientific evidence of the Group A of the highest consensus scored 8 out of 10. Is it applicable to all grades of osteoarthritis? Scientific evidence was very high. The consensus was 8.1 out of 10, and we said it was ideally moderate knee osteoarthritis, but also for severe osteoarthritis. Third question: is it better or worse than steroids, intra-articular steroids? Obviously, everyone agreed it was much better than the steroids with high scientific evidence and without the risks of steroids. Is it better or worse than hyaluronic acid? Scientific evidence was of Group B, with also high agreement, 8.1 out of 10, and we decided it was better than hyaluronic acid, although the acid is not bad. Is it indicated for the osteoarthritis that affects exclusively the patella? The scientific evidence is less here because there were articles in favor and against, and it was level C is 7.4. Does age have an influence? There's little scientific evidence. There are no concluding studies indicating it only works in younger patients. But we all did agree that there was no scientific evidence in this sense, but we concluded that age was not a limiting factor. You can use PRP in elderly persons. Do we have to repeat injection cycles? We all agreed they must be repeated to improve the result, although there weren't sufficient papers, level 1 articles, indicating that it had to be done. Now, the PRP, what it was like, there were over 50 systems, so this was not responded to. If you have any questions, I'll answer gladly. And in terms of protocols, how much and how to infiltrate? Firstly, how many times? Concluding more than once. Scientific evidence was a Group B, but we all agreed that we had to inject more than once. Second question, which we are asked every day: can we give anti-inflammatories to our patients? We all agree, although there are not enough studies because not all have been shown in the literature, but the experts agree that we must not give anti-inflammatories either before or after treatment. I can explain why later. Should we use local anesthesia? Scientific evidence is not high, but all agree that we must not combine PRP with local anesthetics. Can they eat before they draw blood? No one has studied this comparison, but from a basic level, there are many studies, and they all agree that you must do a low-fat diet before the drawing of the blood so that the plasma doesn't have high fat levels, and we have to avoid alcohol because it changes the presence of platelets. So the consensus reached the following conclusion. Firstly, platelet-rich plasma is efficient and safe for knee osteoarthritis in all mild and moderate grades, but we can also try to use it in severe cases. It could be considered as a first-line treatment for knee osteoarthritis, and it is more efficacious than other intra-articular treatments like hyaluronic acid and steroids, especially in the long run. And now, in this consensus, we published our real experience on the treatment with PRP in knee osteoarthritis. What happened with our patients? Since 2014, we analyzed 531 patients treated only with PRP in these years, separated by groups, and severe, moderate, intra-articular or intraosseous application. And the conclusions were very similar. 70% global, including the severe and moderate osteoarthritis. We had 70% of good results beyond a year. Age and weight have an influence negatively, but it's not a counterindication to use this treatment. It's better to use it in mild and moderate grade. And in severe grade, in our cases, we would do intraosseous infiltrations. And when things did not work well, we added a second cycle, which the ESCA agreed to. And we used a PRP that had no leukocytes, no red blood cell, with a moderate concentration of platelets. In osteoarthritis, mild, moderate, only in the intra-articular. In the severe, we also did an intraosseous application. And we did this in special places in our facilities where we only do biological treatment, only applying PRP in these places, which is clean, disinfected like an OR. Blood is drawn in laminar flow chamber, infiltrating with all the asepsis conditions as in surgery, and intraosseous infiltrations we do in the OR because the patient has to be sedated. And we start with radiological control. We're not doing it anymore, and we do it now with parameters and references that we locate with ultrasound and an engine, introducing the trocar in the bone. We infiltrate in the femur and the tibia and sometimes in the patella, and we do the intraosseous infiltration and 2 more times every week or 2. And the last question: are we capable of changing the evolution of this disease that will end up in the prosthesis? How many years can we delay the prosthesis in a patient coming to us who's been told that he requires a prosthesis and that we treat with PRP? We have revised 331 knee prostheses since 2014, excluding the patients who took anti-inflammatories or did other treatments because that was masking the evolution. So we ended up with 186 prostheses treated only with PRP, intra-articular or intraosseous, and the average delay was around 6 years, which means what? It means that we delay 6 years the indication of prosthesis. And in some patients, 16.6% of patients, we've been delaying the prosthesis for 10 years, which has made us go from indicating a prosthesis in the 60s and 70s to indicating it between the 70s and 80s. A patient, 67 years or 68 years, imagine, with problems. You need a prosthesis. The average age, 14 years. At 82, that person might require a change of prosthesis. If we manage to go to 72 years without the prosthesis, the person won't need another revision until 86, which might be beyond the patient's lifespan. So we will spare the patients from all the hassle and the pains and stakes of all the second prosthesis. So these are the conclusions. I don't like to give absolute conclusions of biological treatments because it's a changing world. We've just started with this. We're just starting to learn something. We know that we know little, but that we can learn. So thank you very much for your attention.
Muchas gracias, Dr. Sánchez.
Thank you so much, Dr. Sánchez. Excellent. I want to say that all the speakers are here for free. No one is getting anything. They're giving away their time and knowledge. We have agreed 2 or 3 questions. José Luis, you're always the first. Thank you so much. It's a pleasure to hear you talk. Everything was so crystal clear and hopeful. My question is I'm a little scared. A treatment like this, is it covered by the National Healthcare Services? And what patients would this be? It depends on the region, actually. In some places, it's covered by public hospitals, and the specialists decide who will get it or not. And other hospitals do not do it. It's forbidden. For example, in the Basque Country, in my dear Basque Country, it's forbidden. You cannot use this in public hospitals, but in Madrid and Ciudad Real, there are public hospitals where they can do it, and they are using it. Good morning. I really enjoyed your presentation. My question is somewhat technical in terms of the surgery. Have you had more complications post-surgically or intrasurgically, increasing the age of the patients? Because as a patient is older, surgery could be more complicated. No, a prosthetic surgery is a major surgery with very much rehabilitation, but the surgical risk of a knee prosthesis is well under control. We operate patients with older than 80, and surgical complications, rehabilitation, similar. What we want to avoid is not that first surgery. We want to avoid the turnover or the making the patient's life miserable, because a loose prosthesis is very painful. Dr. Vergés. Same here. I would say that, as the other speakers, I think we have a great orthopedic surgeon that I've known for many years and who has been a pioneer in Spain with PRP, who has greatly fought for this, sometimes encountering many difficulties as I do. And I think you did an amazing job. As Dr. Cugat as well. Many groups in Spain did an amazing job with PRP. I was fortunate enough to visit his clinic, which is extraordinary, with an amazing team, and it's great to see how they work. And I appreciate that you came. I know you had to leave your clinic and your patients to come here, but this is something that we are asked about very often in our foundation, about PRP, and also Dr. Solruiz mentioned it as well. Not everyone is Mikel Sánchez. Not everyone. You have to be careful with who does this, because there are people who work very nicely and seriously, and others don't. So, what can I say? What they're doing is excellent. As Dr. Cugat and other groups, also Dr. Freitag, Karain, who are doing a great job in Madrid, pioneering groups doing great things. Many times we don't have other alternatives, so before a prosthesis, knowing that 80% will go well and 20% won't, it's a very good alternative, and he said it, the sooner the better. This happens with all treatment. The joints, the later you treat them, the worse. So you always have to go to the doctor right away, not when things are bad. Osteoarthritis responds very well in the initial phases and intermediate phases. When there's no cartilage left, things are more complicated. So I'm saying this for all of you, the patients and the relatives, don't let your osteoarthritis get worse. Treat it as soon as possible. Very important. Don't you agree? Yes, definitely. It's easier to avoid harming a joint than curing it. It's always better to take a painkiller before the pain gets bad.
By the way, do we know how that player we saw in the video ended up like? Well, yeah, we have a question from a volunteer. Yes. Over here. We spoke about age. Is there any limit? An 80-year-old, a 90-year-old person? What about the price? Could you share what the price would more or less be of that treatment for people of this age? There's no age limit. Our plasma ages along with our cells respond more poorly, but the older the age, there will be more rates of non-respondence. We have two groups: the patients that improve, that are respondents, and those that do not. People over the age of 80, there are more non-respondents than respondents because their plasma is of a poorer quality, but this does not mean they shouldn't try it. Even if there's only a 60% rate of responders, 6 of every 10 can delay the change of the prosthesis. And if you start a treatment with a respondent over the age of 80, you can almost guarantee that no surgery will be needed for that prosthesis. We're working, but we are limited because of the clinical trials in using halogenic plasma, that is from younger people for older people. And we've started a clinical study that where we can only do this. The conclusion will be that it is much better, for sure. But then we won't be able to use it because there will be a whole regulation of drugs of the Spanish agency, and it will be difficult to do this. We will have to go on a case-by-case basis. But there's an open future for this as well. Well, thank you very much. A round of applause to Dr. Mikel Sánchez. Thank you for coming, Doctor. And have a safe trip back to Vitoria, Gasteiz.
Muévete contra la artrosis, 6º Congreso de OAFI.